Good morning, everybody. We'll just give others time to join us, but good to see a few faces already.
Good morning.
Good morning, Dr. Obi.
Good morning.
Dr. Obi, whilst I've got you, is it going to be both you and Dr. Feisman presenting?
Yes.
Okay, perfect.
Sorry, just a quick question. Do we need to show our face when we start the presentation?
I think that'll be nice.
Okay.
Yeah, that'll be very, very good.
Okay.
So good morning for everyone that joined us. We're just going to give a few minutes for the others to join. If we can ask you to keep your camera off and being on mute, and we would like you to switch your camera on once you are starting to speak. But for now, just very, very welcome. Let's just give everybody a chance to get into the meeting. Right, so we're going to make a start. May I welcome you all to the meeting, to the webinar for today, where the doctors of NES are going to display their academic and audit work. We will have doctors joining us during the day, dipping in and out of the meeting. It was set up specifically so that people can attend or just attend specific sessions during the day. But for those of you that have joined us, very, very welcome. Can I ask you to use the chat function? Maybe ask you to open the chat function if you do have any questions during the presentation. After the presentation, we're going to ask you to to put your questions in, and I'm very happy to ask the questions on your behalf to the speakers. We certainly want to be on time today, so we're going to make sure that we use just 5 minutes for the questions and about 15 minutes for the presentations. I can see quite a few people is still joining us, so very, very welcome. Can I also remind you that the meeting is recorded. We're also going to make use of AI to make some notes for us. Not sure if that's going to work well, but we're certainly going to give it a try today. And then we will have the recording available for all our doctors that is on duty or not able to make some of the sessions today. Can I also ask you if you've opened the chat to ask questions in there if necessary. But then also, if you do want to ask a question and speak out loud, there is the raise the hand question or the function. So very happy for you to use that. There's also the reactions available. So if you want to use any of that, maybe for the speakers, if you want to send them a thumbs up or the applause. And I wonder if I can ask you just by way of introduction to see if you can go to the react button and just either give me a thumbs up or a clapping of the hands function for the participation today and for the speakers. Thank you. I can quite see a few, so thank you very, very much. I think it will be absolutely appropriate if you are listening to the speakers to provide them with a reaction. It's always good to see, specifically if we don't see all the faces during the meeting. Now, I'm just going to check if we have got Dr. Ovat and Dr. Obi. If you are online, happy for you to switch your cameras on and come off mute, that I can at least say good morning to you before we start with the presentations. Oh, good morning, Dr. Obi.
Good morning. Still waiting for my colleague Fateman.
Now, I know Dr. Faceman is on duty today, so it could be that he's busy. So we'll just give him a few minutes. Dr. Obi, I wonder if we start with you, maybe just as an introduction, just some background, maybe just introduce yourself to us.
Okay, thank you very much, Dr. Krosky. My name is Annabelle Obi. I am a resident doctor. I've been with NES since June 2024. I've worked stationarily in Spire, Leicester, and now I'm currently in Nuffield, Wolverhampton. The audit that we are presenting today is from Spire Leicester. So we did that audit while we were working at Spire Leicester, and we're really grateful for the opportunity to present. I'm also happy to meet other participants and get to make new friends today. Thank you.
Yes, and how long have you been with NES?
Since June 2024, so that would be a year and almost 2 years now.
Wow, and already presenting one of the audits.
Yes. Well, I would say with the help of my colleagues and also having worked with people who were interested in that sort of boosted our confidence and helped us to go on with it despite the challenges.
Right, fantastic. Erika, I wonder if I can ask you to start loading the presentation for us. Oh, fantastic. If you can just give us one of the reactions to say that you can see that clearly on your screen, that'll be fantastic. That's perfect. Right, we'll just give a minute for Dr. Overt to see if he is joining us. Dr. Obi, I'm not sure if you are starting the presentation or is he finishing, or how did you divide this between the two of you?
Yeah, he was supposed to start, but it's fine. We've gone through it, so anybody can start at any time. So I'm happy when you're ready.
Right. Let's just give him another minute. I want to be fair to him, because I know that that both of you have worked really hard on this specific presentation.
Thank you.
Alexa, reduce the volume.
Right, so just before we start, if I can just ask you to make sure that your camera is off and that you are on mute, and very happy for you to pose any of your questions in the meeting chat. Please don't use the question and answer function. Use the chat function if you do want to put any questions forward to the speakers. Now, I think on that note, Dr. Obi, very welcome at the presentation. If Dr. Overt is joining us, happy for him to jump in. Erika, if I can ask you to send him a message to say that we've started and that he's welcome to pitch in at any time. So, Dr. Ovi, all about the adequacy of GP discharge summaries released from the surgical inpatient ward using the professional record standards body guidance. So very, very happy to listen to you.
Okay, thank you very much. Before I start, I would like to say thank you to NES for this opportunity to present our work. And we've worked hard for this audit and this presentation, and we're very grateful for the opportunity to present it and also listen to other colleagues on their own presentation. So our audit was about the adequacy of GP discharge summaries that were released from our surgical inpatient ward, and we used the professional record standard body, that's the PRSB guidance. Next, please. Next slide. Okay. So first of all, we had to understand the importance of this audit, and we're auditing discharge summaries that were written. So just a basic background, a discharge summary is an interprofessional handover that explains the reason for a patient's admission, explains the events that occurred in hospital, and also provides details needed to continue the patient care in the primary healthcare center. Next. So discharge summaries have a certain structure that should be followed. So, and the essence of this structure is to enhance continuity of care, to encourage timely transfer of precise details of patients and all their relevant professionals that manage them. And also it's aiding in secondary processes such as research and audit, because when a discharge summary is written properly, it serves as a form of data when researches and audits are being done. So this is because discharge summaries, especially the ones from hospitals, in hospitals, is to give information to the next person who is supposed to take over the patient's care. And in the UK, the primary care healthcare provider for a patient is the GP. So we can say that the GP basically owns the patient, and every other person is just borrowing the patient for the meantime. And then when you're done with the patient, it's your duty to return the patient to the GP so that the GP can continue the care that you have started. And also, if there's any update, the GP can update you to um, review the patient again. And then, so it's just the back and forth process. When you review, you send back to the GP, and the GP will not know what has happened in hospital if the discharge summaries are not written properly. Next slide. So in 1996, a group of nurses came together. This was when discharge letters were done by hand, so they were written by hand. So they came together and they got about 260 GPs and asked them what they needed in discharge letters, what were the most important things. And the GPs said in that time that the investigation results, diagnosis, treatment, and follow-up arrangements were the most important things that they wanted to see after a patient had been discharged. And then by 2008, the Royal College of Physicians published a clinical heading that showed the required documentation on admission, handover, and discharge were very, very important, and especially when electronic records started, and we moved from writing by hand and typing in the computer. Next. So the aim of our audit was to enhance continuity of care in our surgical inpatients through detailed hospital discharge summary. Our objective was to make sure that the requirements for these discharge letters were met. So the requirements are divided into the mandatory, the required, and the optional. So the mandatory requires that you have 100% compliance to it. And for the required and optional, you can have 90% compliance to it, depending on the kind of institution or hospital environments that you have. Next. So the PRSB, I know I've been saying it's an organization in the UK that makes standards. They make guidelines, and then they also help the NHS and other health organizations to implement these standards by teaching, by educating, and all that. So basically, that's their job, and this was the standard that they created for discharge letters, which the whole of the UK uses. Next, please. So these are the standards. So before I start, what drew our attention to discharge letters was because one of our patients had a joint replacement and went home. However, we had started a treatment for UTI, and the patient also had some memory problems. And when he returned to the GP was not aware that treatment for UTI had started. Patient also was not aware because he had forgotten that he was on treatment for UTI. So there was a problem. So we received a letter from the GP stating that they were not aware of patients starting treatment for UTI, although the patient had antibiotics with him, which he did not take. So he only took a few doses in hospital and stopped when he got home. So no appropriate discharge letter written. Relatives also were not aware properly of how to continue the antibiotics at home. So that was what made us to look at the discharge letters that were written in our facility to be sure that we had a standard, we were adhering to a certain standard, and that's the whole origin of the audit. So for the PRSB guidance, you have the mandatory, the required good practice, and the optional from top to bottom. So for the mandatory, it's required that you have 100% of this. Most of the software used in the UK, in the NHS, and other hospitals have automatic data collection. So things like patients' demographics are automatically imputed. So the others, you have to type them yourself. So patient demographics, admission details, diagnosis, discharge details, clinical summaries, allergies and adverse reaction, the person completing the discharge letter, and then the distribution list. The distribution list is who gets the letter and who's, to receive it. The required good practice and the optional. So, and a rule is that you do not downgrade a required good practice into an optional, and you don't upgrade the optional and make it required. So, but you can, as much as you can, do what you can do in your own facility that applies to you. Things like individual requirements, procedures, medications and medical devices, safety alerts, plan and requested actions, and the others. And for the optional, we have the participation in research, assessment skills, social context. So all those ones are depending on the environment that you are receiving this patient in. Next slide. So this is just a typical image of what happens when a discharge letter isn't written properly. You see a patient with a shoulder sling and he's telling the nurse that he didn't have a tummy tuck and because information has been switched. So next. So the methods for audit was a retrospective audit. So we audited day case and inpatient procedures in the month of September 2024. The discharge letters were reviewed using the system application and product software called SAP in our hospital. And then we used we use Microsoft Excel to analyze our data. And then we executed our audits using the PDSA, which is the Plan, Do, Study, and Act cycle in audits. Next, please. So our outcome, so for the first cycle, the problem for the plan, the problems we wanted to know was there any existing level of compliance with this PRSB standard? Was there any standard that our facility followed in terms of writing a very comprehensive discharge letter? And then the objective was to just get our own data to know the level of our compliance. So our intervention, we audited all the surgical ward discharge summaries from the month of September. We had about 366 letters that we looked at. Next, please. So this is the outcome of our first cycle. So in blue, we have those that were included in the letter, and in red, we have those that were not included in the letter. Based on what we have, we can see that we had 100% in discharge details, admission details, patient demographics. And this is because the system automatically created this based on the patient's information. So it would always be 100% for this part. And then when we look down to the last, we'll see clinical summary. Clinical summary was about 9.3%. That's like all the discharge letters had no clinical summary. That's what it's just saying. Only 9.3% had a clinical summary. So that was a very, very, very poor outcome. We did not expect to see this in the audit. Next slide. So, and then for the required and the optional, again, like I said, some informations are not on this software. So the facility decides what they add and what they don't add. So most of these red lines we're seeing did not exist on the software. So there was nowhere to impute them. Things like referral details, which means who referred the patient to the hospitals. And most times it's the GP that does that referral details. So hospitals can decide to choose GP details over referral details. And then expectations and wishes were not included. Patients and carer concerns. But the major parts for this in the required was the plan, requested actions, medication and medical device and procedures. For the plan and requested actions, we had about 50% that completed it. So the plan and requested action included what the what the plan was when the patient was leaving the hospital, if the patient needed to come back for a follow-up or not, or a wound check and all that, those were supposed to be imputed. So only about 50% had that. For the medication and medical devices, we had about 69.9% that had that. Every patient should have their medications written in the discharge letter, and I will explain the reasons where we go forward. For the optional, so the most significant thing from the optional was the investigation results. So that was about 6.2% that had investigation results written. Next, please. So this is like an overall study of the comparison with our first cycle and the standard. So initially we said that the standard, the mandatory, requires that you meet 100% target, while the optional and the required, you can do 90%. So the white color is our target, while the blue is our audit results. We can see that for our mandatory, overall, we had about 89.3%. So that's courtesy of the already imputed data that comes automatically with the websites. And then for our required, we had about less than 30%. For the optional, we have 60 something percent, almost 70%. And yeah, that was the first outcome of our cycle, of our audit. Next, please. Okay, so first cycle outcome, what we did after we got our results, we had a meeting with the managers, the ward manager, the nurses, and also had a meeting with the non-clinical staffs where we presented our audits, we showed them the outcome, and then we also acknowledged the gap of the PRSP requirements in our presentation. Barriers like that's prevented the implementation was the software. First of all, we had the closed-ended data entry field that's made it difficult for the nurses to impute their information. And then some forgotten clinical details, especially for patients that had extended stay in hospital. So details were forgotten and it was not passed or handed over to the next person. So, and then the way they changed the shift. So the day staff might not give all the information to the night staff, who might be the one who discharges the patient. So things like blood results and, having low blood pressure post-op or hypertension post-op or having multiple vasovagals post-op would be forgotten. So the night staff who comes and sees the patient looking all well does not remember to put all those details if she's the one discharging. Next, please. So what we said we were going to do was we explained the importance of a clinical summaries. We explained what a clinical summary was. And then because of the software issues, we were able to come together and decide that for the clinical summaries, the nurse would have GP information as that headline. So that's the information for the GP. Then for the information advice for the patients, we would have patient information for that. And then the plan was to also re-audit and then fill and save important care details on the website daily. So as they're happening in real time, we're to put them in the discharge letter so that we don't forget. And at least when the next person comes in, even if someone hasn't been there for 3 days and comes in and it's on his or her shift that the patient is being discharged, they would be able to see all the information that from the previous days in their absence and include that in the letter. Next. So after that, we audited our second cycle. Don't know if my colleague is here. Yeah, so we went into the second cycle. So the clinical summary was the major problem from the first cycle. And then the improperly filled sections like the plan and requested action that did not provide any useful information, allergies and adverse reaction, medication and medical devices. We had instances where the allergies were written as C notes. So C note is not enough because if somebody who has no access to the patient's notes sees that, they wouldn't know what the patient might be allergic to, and even if there's no allergy. So we discussed this, and also for the medication and medical devices. Sometimes patients go home without any TTOs. So because it's a simple procedure, they don't need any extra pain relief aside the paracetamol and ibuprofen they have at home. So, but they were left blank because of that. So we had to inform everyone that even if there was no need for a TTO, you needed to write that patients will take their own medication home or would take their medication at home or no medications required so that you are not confused about the details. And then the relevance information like blood tests, whether it was the UNE, full blood count, whatever was reduced and needed to be reviewed in a few weeks or a month, like HB, patients with HB that are low but does not require blood transfusion. It was very important to note that so that the GP could review that later and see if the patient had improved in terms of their blood work. Next. Okay, so the objective again, like the first one, was to ensure that we met 100% in the mandatory and 90 in the required and the good practice. So what we did, we're able to bypass the restrictions, entering clinical summaries in open-ended spaces so that it would be able to seem more presentable and it would not be missing in the discharge letters. So most of the staff didn't understand what a clinical summary was. They assumed that every other thing was the clinical summary, but clinical summary was supposed to include what the patient came in for, pre-op, post-op, the outcome, how the patient fared post-op, if there was any issues that happened post-op or pre-op, if there's any significant findings intra-op as well, and those things were needed to be written, and what the outcome and what we're waiting for, if there was any samples taken and when the samples will be ready for histology and all those. Next. So from our second cycle, these are just explanations that we gave and things that we did to improve the second cycle. And then we did the auditing in January. So from September, we gave time for the nurses and every other person to improve. And by January, we re-audited. So we had about 276 summaries this time around. They were lesser. And I suppose it's because of the January holidays and all. So next. So this is our outcome. So we can see that the red color has reduced for the mandatory. So we can look at our clinical summary. So from 9.3%, we moved to about 80% in the clinical summary. So this was a very, significant improvement, and we are quite happy with the staff. Everyone was happy about this outcome, and the others are still the regular ones that are automatically filled by the computer. Next. So for our required and optional, we still have reds because these informations don't exist on the software, so we're still lacking behind. But the significant thing that we wanted to note was the medication and medical devices, which improved. And from the optional, our investigation results also improved. Next slide, so we can better see. Yes, so this is a slide that explains the first cycle versus the second cycle. So again, our target in white for mandatory is 100%. Our target for good and required, optional and required is 90%. So the first cycle color is blue while the second cycle is red. So overall, we can see that we improved, even if it wasn't so much, but there was an improvement. So that's why the audit is open for re-auditing as needed. Next. So this is another slide that shows the significant changes from the first cycle versus the second cycle. So for the mandatory, first one, blue is cycle 1, red is cycle 2. So clinical summary, you see how we move from less than 10% to 80%, and our allergies and adverse reaction also improved. So overall, there was an improvement in this audit. So first cycle versus second cycle. Required good practice. We have an improvement in our medications and adverse reactions, and the plan and requested action also improved. Next, please. So after our second cycle, this was what we drew up. Unfortunately, we had moved on from the facility, but however, we transferred the audit to the next doctors. We left it with the ward managers to have this audit open for re-audits so that there would be annual or biannual re-auditing. The plan was that they should have more ward meetings, print out posters and reminders, daily reminders for the nursing staff to impute the audits and to follow this PRSB standard in terms of imputing the audits. And 2 cycles are not enough. We need more if we want to look at a long-term improvement in this area that is lacking. Next, please. So for conclusion, the major unidentified deficiency in this audit overall was the clinical summary, which we improved on, and we're hoping that they will be able to improve better as the year goes by. We use staff education, improved our documentation, effective teamwork. We worked together with everybody. The ward manager was very active in reminding the nurses. We were looking at daily discharge letters. So every time it was written, we were able to review it. We had colleagues asking us to review, could you look at my discharge letter to see if I've missed anything? And that was a very good way to, to work together. So if anything happened, we would also tell them, please, could you add this in the discharge letter so that the GP is aware of this? If we stopped any medication, especially patients with loads of medication, sometimes you have to stop them so that, if you don't reduce their sodium, you don't cause any other electrolyte imbalance because of their procedure. So we needed to include that in the letter so that the GPs would know that, oh, we had stopped these medications and the patient is to continue when you're happy for the patient to continue. So it was a very good experience. The teamwork was superb, and we're happy to have done this. The nursing staff, the hospital management was very, very happy that we did this audit. And then our second cycle showed demonstrable changes and improvements. And also, like I said, the ongoing reinforcement and regular re-audits are very necessary to obtain and to sustain this compliance. And that's why we have handed over the audit to the next doctors there to continue it and make sure that it's a continuous and ongoing process. Thank you very much.
Dr. Obi, thank you very, very much in the absence of Dr. Feistman, who did the audit with you. A fantastic example. Someone once said that, the audit is only good if there's a re-audit. And clearly you've shown significant results with that 80% clinical detail that were improved. So improvement for the system, improvement for the patient. Thank you very, very much. There was no questions that came in from the chat, but can I ask you, with the using your reaction button, maybe to give some appreciation for Dr. Obi and Dr. Ovat for this fantastic first presentation. So, Dr. Obi, thank you very, very much.
Thank you.
Much appreciated. I know you've only got 15 minutes to present, but it's hours and hours of work that actually went into these specific audits and studies. So thank you very much. Now, that leaves me with just a half a minute to welcome Dr. Uzaze. If I can ask you to switch your camera on, and maybe Erika, if you can load the slides for us. Dr. Uzaze is going to talk about an audit of adherence to the local trust standards in the diagnosis, initial management, and escalation of post-operative hyponatremia following joint replacement surgery at the Cambridge Spire Hospital. So, Dr. Uzaze, can I ask you just to introduce yourself?
Thank you very much. I'm Dr. Osaze Ehiogai, and I've been opportunity to work with NES at the partner hospital, that's Cambridge Spire Hospital in Cambridge. This is my 21st month, and I started in 2024 June as well. Thank you very much.
Yes, so very, very welcome, and we are very happy to listen to you. And may I just remind the participants, if you have got any questions, put that into the chat function for us. But very happy, Dr. Zazi, for you to take over.
All right, thank you so much for the opportunity again to present. So this is an audit of post-operative hyponatremia following joint replacement surgery. It's an audit of adherence to the local trust standards at Cambridge Spire Hospital. I am the audit lead, and I worked in handy with Doctors Mustafa Abdulsalam, Doctors Abid Babatunde Oyedele. And, this was supervised by the consultant anesthetist here, Dr. Abdullah. Next slide, please. So I will run us through the following outline from background to the conclusion. Next slide, please. Now, hyponatremia is the most common electrolyte disturbance in hospital practice, and in orthopedic populations, particularly in elderly arthroplasty procedures, it has actually been associated with increased morbidity and mortality. In a large United Kingdom study, the prevalence was found to be about 21%. And despite good understanding of the pathophysiological mechanisms and interactions, several studies have actually demonstrated a variability in how it is investigated and managed. So this prompts the audit in our hospital and the rationale for evaluating the local practice seen in Cambridge Spire. Next slide, please. The primary aim of the audit was to assess how closely our practice aligns with the local hospital protocol and standards. We were particularly interested in whether diagnostic evaluation, including volume assessment and urine studies, were being consistently performed. Next slide, please. The audit standards were carefully derived from the Spire Healthcare Hyponatremia Guidelines, which align with national guidelines such as NICE and European Hyponatremia Guidelines. And it was broadly grouped into three domains: the diagnosis, initial management, and escalation. Specifically in diagnosis, we looked at documented volume status, prompt repeat of serum sodium or serial sodium monitoring, and urine studies, especially in moderate and severe cases. In terms of initial management, we looked at if initial active treatment was initiated following diagnosis, and if there was a structured sodium correction put in place. And for escalation, we assessed how escalation was done to the senior review. In this case, the anesthetist or the consultant surgeon, and then referrals to higher level care, as the Spire is a level 0 facility and will not be able to manage severe symptomatic cases. Next slide, please. For the methods, it was a retrospective single center clinical audit that was conducted between April and December 2024. And during this period, 781 elective primary hip and knee arthroplasties were performed. 28 patients developed post-operative hyponatremia, and these cases were then assessed against the 7 predefined standards, which I discussed in the previous slide. We included, next slide, please. We included all adult patients within the time frame from age 18 years and above who underwent elective total hip and knee arthroplasties and had documented post-operative serum sodium of less than 135 millimoles per liter. We excluded patients with pre-existing chronic hyponatremia prior to surgery and patients admitted for revision on non-elective orthopedic procedures. Incomplete clinical records were also excluded. Next slide, please. Now, during this audit period, as I mentioned, 781 elective primary joint replacements were performed, and the prevalence of postoperative hyponatremia in our study was 3.6%, which was quite low compared to a general UK study, a similar UK study that I mentioned earlier on. The mean age was 75.8, which was predominantly elderly, and it was predominantly female as well, the population. Next slide, please. So the chart shows the summary of the compliance with the audit standards, and concerning low with documented volume status and urine studies, and this was in the initial diagnosis. So this was 0% actually. That is concerning, as despite hyponatremia was diagnosed in all patients, um, there was poor volume documentation, and urine studies were not performed at all. Encouragingly, active treatment was started in all patients, and it was also escalated to the anesthetist for review in all patients as well. We had 23.1% transfers. This was in cases of severe symptomatic or hyponatremia less than 120 millimoles per liter, according to local trust protocol. Next slide, please. Now, the table shows the diagnostic compliance according to the local hospital guidelines. As I mentioned, it was concerning that volume status was not documented at all, and urine studies were not performed at all. Serum sodium measurements were done in 92.2%, 92.9%, which was quite encouraging, as it shows that the clinicians and the resident doctors had a mindset to monitor this closely for possible deterioration. Next slide, please. Now, in management compliance, so we could see from the table that active treatment was initiated in all cases, and fluid restriction specifically was initiated in all cases. Active treatment was directly proportional to the severity of hyponatremia. And to buttress this, intravenous fluids were given in 83.3% of severe cases as compared to 28.6% in moderate cases. Also, slow sodium was initiated in 83.3% of severe cases as opposed to 47.6% in moderate cases. So this shows that there was some clinical reasoning and rationale for treatment in this. However, we could infer that it was more or less from broad or general just feelings of correction, and it wasn't guided by actual protocols or guidelines. Next slide, please. In terms of escalation compliance, all cases were escalated to the anesthetist for review, especially the moderate and severe cases. And we had 23.1% of transfers to the nearby NHS facilities for further management. Now, to discuss our findings, next slide, please. Our findings demonstrate a good recognition and timely biochemical reassessment with universal initiation of treatment. However, formal diagnostic classification was absent, as could be seen from the results and specific compliance data. Volume status was not documented at all, and urine studies were not performed in any moderate or severe case. That's quite concerning. So this suggests a systematic gap in guideline-driven diagnostic assessment. Also, our observed prevalence of 3.6% which was lower than the reported 21.7% in a similar UK study, could reflect under recognition or under documentation rather than a true lower incidence. Escalation was senior led, but not always aligned with structured thresholds of management. Next slide, please. The limitations to our audits, as this was a retrospective audit, and therefore it depended on the quality of documentation. So it is actually possible that volume status documentation or volume status assessment was actually done, but not just documented. The study was also conducted at a single center with a modest sample size. So the calculated prevalence may actually underestimate the true incidence if mild and transient cases were not captured. I mean, this is in comparison to larger NHS trusts where we will have a robust volume population. From our audit, next slide, please. The following recommendations have been made, which have been instituted. To improve adherence to local trust standards, we propose introducing a structured hyponatremia pro forma and embedding volume assessment prompts into routine documentation. Also, urine investigations should be standardized in moderate and severe cases. Escalation thresholds should also be clarified and visibly accessible. Targeted education for junior doctors and nursing staff will be essential to improve recognition and classification. These are low cost and system level interventions that can be readily implemented within current workflows. A re-audit, very important, has been planned within 6 to 12 months to assess the impact. And these recommendations have been discussed with the clinical governance team in the Spire Hospital year. And it has also been discussed in multidisciplinary meetings with members of staff, the nurses especially, which could implement some of these. Next slide, please. In conclusion, our audit demonstrated an overall prevalence of 3.6% in this cohort. Recognition and senior involvement were strong. However, diagnostic documentation, particularly volume assessment and urine studies, were quite deficient. Escalation thresholds were not uniformly applied as well. These findings target key areas for improvements in the Spire and generally, and suggest that relatively simple system-based interventions could actually improve adherence to local standards. Thank you very much.
Dr. Saze, thank you very, very much. I've seen over the years that hyponatremia caught quite a few doctors unaware. So well worth the study. And I think the only way to look at, what is really out there is to do an audit. You showed the 3.6% versus 21%, which is actually very, very good outcomes. I've got a question from Grace asking, urine osmolality studies are not feasible in some private hospitals and senior colleagues are often unwilling to transfer or pursue this route. How is this reconciled? So maybe you've done this in the private, so any ideas?
Yeah, so, okay. I was expecting this kind of question. And so following this audit, we discussed with the matron and the ward matron and nurses in charge. And we've actually implemented it in the Spire year that any hyponatremia case, irrespective of severity, urine osmolality samples must be sent. And to this end, we implemented it in such a way that the nurses routinely take the samples, that's the universal urine bottle, and send it over to the lab by status quo. So we don't need to remind them. However, an additional thing we did was what we proposed to do is to have sort of a prompt that's the sort of the clinical guidance prompts as a reminder, which you have to tick to indicate that it's been done. and then that would be re-audited in the second loop. So it's very possible, actually. I think it just requires the resident doctors taking care to inform the nurses.
Wow, so that is very, very interesting. For the volume assessment, would the advice be to start before sodium levels are checked or after hyponatremia has been confirmed? And this is from Daniel.
Yes, thank you very much, Dr. Daniel, for the question. So the way we do it, so sodium U and E's or routine bloods are done day one post-surgery. So when it is recognized or diagnosed, immediately what we do or what I do is to go back to the patient and reassess. Now, volume documentation or volume assessment is actually a simple bedside procedure that could be done, and it involves looking from the history that if the patient feels dehydrated, or in some cases, one of some patients have actually been starved or dehydrated for longer durations than expected. And then from clinical examination, looking at the buccal mucosa for buccal dehydration, sticking out the tongue, as simple as that. And then we check the chart, the input-output chart, what is the input and what has been the output so far. From that alone, you can actually tell if it is euvolemic, hypovolemic, or hypervolemic, especially from the urine output. So it's very feasible, and this can be documented in the assessments, the clinical assessments, which can be acted upon and audited retrospectively.
Yeah, absolutely fantastic. Dr. Uzazi, thank you very, very much for, again, hours of work that went into this study. When I saw it first, I thought it's something worthwhile, to bring to all our hospitals, specifically with the hyponatremia. So thank you very, very much. I wonder if we can ask you, just using your React buttons, maybe just to give some appreciation for Dr. Uzazi. So thank you very, very much indeed for spending time with us and presenting this very interesting audit with us. Much appreciated.
Thank you. Thank you very much.
There's still a few other questions that we might answer later. We are running out of time, but thank you very, very much, Dr. Uzazi. Now that brings us to our next speaker, Dr. Hamza Masood, and this is a case record. I just want to check if we've got Hamza online. Hamza, happy for you to switch on your camera, and would you like just to introduce yourself? You're just on mute still.
Hi. Hi, my name is Hamza Masood. I've been with NES for the past 3 odd years. I work in Queen Elizabeth Queen Mother Hospital in Margate. And this is a case report. I know it's a bit different from all of the audit work that we've been doing, but just wanted to give it a different touch. I am actively involved in research and such, and have been trying to improve things in the hospital as well.
Yeah, fantastic. I'll ask Erika to load your slides. Now, we are talking today about quality improvement activities, and of course, a case study is one of those quality improvement activities which doctors can and should add to their appraisals. So, thank you very much for bringing this this example to us. Happy to listen to you.
Sure. This case has now basically been published in Wiley Journal, but generally speaking, this was a case from last year. We had a lady that came up to us in the same day emergency care. We have a cancer day unit, and they recommended this patient come in to us. She has been having recurrent hypokalemia, dyselectrolytemias, low magnesium, and such. And this would be the case about it. Next slide, please. So just a background about this case. She's a 68-year-old female, as I mentioned, came to us to the same day emergency care from the cancer day unit. She had low potassium, calcium, magnesium in her pre-chemotherapy bloods, and basically the main reason they sent her to us was to have a replacement and go back. Another background is she's been diagnosed with small bowel cancer. She has liver mets and possible bone mets along with other other meds to other places as well, and she's been planned for palliative chemotherapy. She has a background of chronic kidney disease, hypertension, Crohn's disease. Crohn's disease would be very important later on as well. And her only presenting symptom to us is that she's just been tired, and she contributes that to the chemotherapy and the cancer. Next slide, please. So, uh, I believe when I saw her, this was her third or fourth admission to the same day emergency care. She had been coming in daily to have these treatments. We would give IV potassium, we would give IV magnesium. However, next day she would come in. Potassium was the main thing that recurrently remained low. The reason the Crohn's disease and the procolectomy was important because we wanted to see if she was having loose stools through her stoma. However, on more history, we found out that stoma status was unchanged and she'd had no vomiting, so no electrolyte losses were known. She had one admission afterwards with chest pain, and we did a cardiac workup on her because of the low potassium, and everything seemed to be normal. Next slide, please. Um, these are just a few initial investigations that because we were not able to get on top of the potassium or the magnesium, so we decided to do a bit more workup. The potassium was 2.23, low calcium, low magnesium. Uh, then we started looking into neuroendocrine tumors. We started working her up for ACTH, cortisol. We took a urine cortisol as well. And as you can see, the ACTH was high, the serum cortisol was incalculable, it was so high, and the urine cortisol was generally high as well. I've made an image of how the negative feedback mechanism would work. We can see that the negative feedback mechanism is generally not working in this scenario. Next slide, please. Um, the good thing is because she was good or bad thing for the patient, generally speaking, that because she was a cancer patient, she had been extensively worked up. She'd had multiple imaging done for staging and such. She'd had a PET CT recently. I think it was a month before her admission. It showed a small bowel lesion, extensive liver mets, benign adrenal lesion, thyroid nodules, and she'd had MRI pituitary as well, which showed a normal gland, and she had a thyroid ultrasound, which showed some small nodules. These were further worked out. The benign adrenal lesion fortunately ended up being nothing, and the thyroid workup was also done. She, I believe, had a biopsy, which showed nothing as well. Next slide, please. So, this was after we spoke to endocrinology. Our main hospital that we contact for help, generally for neuroendocrine tumors and complicated cases, is King's Hospital. So they suggested that we send, because she had already had a biopsy, it was easier for us to call a pathology department and ask them to run the test. We didn't need another biopsy for it. Um, Multiple samples were sent. These are all well-known immunohistochemical markers and allow for neuroendocrine differentiation. CEA, again, associated mainly with adenocarcinomas, but it can also be found in neuroendocrine tumors, which are purely differentiated features. Um, PAST or a periodic acid shift test with digestion is used to highlight mucin producing cells, and it's also seen in adenocarcinoma. So majorly all of these were to work her up for adenocarcinomas secondary to gut. Next slide, please. So once we did all these tests, we found that this was in fact a neuroendocrine tumor. What became of our management approach? At this point, while we still hadn't majorly figured out that this isn't a neuroendocrine tumor, but our suspicion was high. So most important thing is I've written in the end, we needed multidisciplinary team involvement. This patient needs endocrine team, she needs ITU, oncology, pathology, especially because she was becoming more and more symptomatic now. So she needed IV potassium replacement. And generally, we know that if we're going more than 10 millimole per hour, we need ITU support to give the potassium. Generally speaking, wards I think allow 20 millimole per hour, but in some cases, 10 millimole per hour is done as well. ITU generally if we need faster, especially when you're bolusing potassium to keep check on the heart and such. So we gave IV electrolyte replacement. We spoke to the palliative team because the chemotherapy had been missed for quite a few days. And the palliative team suggested capecitabine to get on top of the neuroendocrine cells and give us a chance. The dexamethasone, because we were suppressing the We were generally suppressing the tumor. We were worried that her cortisol levels might plummet, so the dexamethasone was to help with that as well. The most important drug in this scenario was metarapone, which is basically an ACTH receptor inhibitor. And generally, when the ACTH levels go down, they help to bring down the overall cortisol levels as well. Next slide, please. This is just generally like an information of what drugs and what their mechanism of action is. Octreotide was one of the drugs that we used. It is well known to be used in growth hormone related tumors, acromegaly, and such. But in this case, we started using this uh, as a for hormone inhibition, growth hormone decrease, and it also helps decrease GI hormones, gastrin, secretin, vipomas and such, because what happens is whenever you try to give octreotide, the amount of secretions decrease. This also helps keep some of the electrolytes inside as well, because when we try to bring the cortisol levels down, the patient started having high stoma output later on. And again, it also helps in inhibiting tumors as well. Next slide, please. Again, a mechanism of action of how the hydrocortisone works and how why we used it. It has inhibitory actions on the 11 beta hydroxylase, 18 hydroxylase mechanism of actions, and this is how the negative feedback mechanism helped us. Next slide, please. Again, major complications, we can understand the complications quite easily with how cortisol release happens. High cortisol would lead to Cushing's syndrome, which would lead to hyperglycemia. Again, as we can see, hypokalemia occurred, cardiovascular risk factors occur in Cushing's, hypertension can occur, low potassium can lead to cardiac arrest as well, weakness, pains, fatigue, which was the main symptom presenting to us. Um, and what are the neurological impacts as well? Neuropsychiatric functions such as depression, catatonia can occur as well. The important characteristics of these tumors, ACTH deleting nets are very, very aggressive. They require advanced imaging. In her case, it was good that we just had the imaging for staging, which helped us in the diagnosis quite quickly. Um, a definition basically, we found out this was an ectopic ACTH syndrome because the tumor was coming from her gut, tumor outside the pituitary, and they're often hard to localize. Next slide, please. So why this case was important and why this ended up getting published? There were three main things. Um, Multidisciplinary teamwork, very important. Especially if you're not finding a cause of recurrent hypokalemia, hypomagnesemia, and especially if patient has a background history of cancer, it's always worthwhile looking into ACTH syndrome. Uh, Hormonal investigations, imaging, pathology, all are important to help in diagnosis. And yes, of course, monitor for complications as much as possible. Next slide, please. Any questions? And in general, if anyone would like to get involved in research or such, I'm happy to help out. We are regularly publishing researches in our hospital. Fortunately, I've been able to lead, I think, 5 to 6 papers and hopefully go forward from there. Thank you.
Yeah, Dr. Hamza, thank you very, very much. Very interesting, the ectopic ACTH syndrome that you brought to our attention. Well worth a case to make us aware. And I think for most of our doctors working in post-surgical environments, this was a fantastic example just to dip our toes back into the world of neuroendocrine, which is maybe one of the more difficult subjects. I can't see any questions in the chat for now, but I wonder if I can ask you specifically at the hospital where you work, what would be some advice for doctors, if there is an interesting case study that they want to get published? Because it's one thing to have an interesting case study, but you have managed actually to publish this as well. So well done. Any advice?
So, generally speaking, I would suggest reaching out to your seniors. This was a very, sorry. So this was relatively more interesting case, and I felt that this could be published in a a relatively better journal. Of course, all journals are good, but this was Wiley being one of the more major journals. I spoke to one of my acute medicine consultants who was the consultant I was working with. He did give me suggestions, but I did have a background with research and such, so this publication generally went easier. And I feel like once you've published once or twice, it is relatively straightforward. Getting senior support generally to just edit and have a look at what you've done is a lot better this way.
Yeah, and certainly for quality improvement activities, whether you just present a case study or if you get it to publication, every one of those will be worthwhile to do. So thank you very, very much. I can see there's some comments saying very detailed, interesting case, and there's even some people asking for your email address.
Uh, I'll put it in the WhatsApp group. I'm happy to be contacted. Uh,
Yes, if you put it in the chat box, then people can see it. We will ask you also if you do have any ideas following today, or if we can help you to publish. One of the ideas after today is to bring a small group, um, or to establish a small group that can help doctors if they want to do more audits or publishing, because I do think we've got a wealth of knowledge that we've unutilized within NES. So thank you very, very much, Dr. Hamza. Well worth a case to listen to. And again, I appreciate all the hours that went into that. It is not just a few slides, it is actually hours and hours of work. So thank you very, very much. I wonder if I can ask you, if you haven't used the React button yet, just to use that to say thank you to Dr. Hamza. Right. That leaves me with the introduction to Bertie. Bertie, I'm sure you are online. If you would like to switch your camera on, and Erika, if I can ask you to load the slides for Bertie. And Bertie, I wonder if I can ask you. I know you for several years now. If you can introduce yourselves, and how many years have you been at NES?
Good morning, Dr. Drotzka. Thank you very much for the opportunity for presenting my audit in the symposium. Yes, so I joined NES in 2009, and it was Dr. Drotzka who personally recruited me 17 years ago, and I came back to NES in 2019 because of my PhD, but I've successfully completed whilst I was a resident doctor. And I also obtained my Royal Society membership since. So I can very proudly say that I worked for NES throughout those years. And I would like to thank you to NES for all of the opportunity what they've given to me. And I can see among the audience my very first MSM. Her name is Rachel. So it's nice to see you as well. Basically, I decided to audit our healthcare professional staff ALS knowledge because of two specific incidents, and I think all of you doctors. Everyone is a little bit stressed when there is an emergency situation in the hospital, and I'm sure you know that teamwork is the most effective way to deal with these kind of situations. So if you were alone, you couldn't sort out resuscitation effectively. You need someone, a team who helps you throughout the resuscitation event. And we carried out this audit with my very good colleague, Dr. Mustafa Afiz, who is a brilliant intensivist and at the moment works in Glasgow. I work in Albine Circle in Scotland. So the events led to this audit specifically. There was a resuscitation scenario in June 2025, when we had an asthmatic patient who collapsed and required went into peri-arrest into a peri-arrest situation and required full resuscitation. In the feedback of the independent feedback provided, which was provided to us, showed that the staff was struggling to find the proper adrenaline syringe, they didn't know the proper adrenaline dose. They were struggling to carry out a safe defibrillation. I think this already a red flag because these things are the bread and butter of resuscitation. And specifically, I was involved in an incident where a member of staff around 11 o'clock in December 2025 collapsed almost whilst cleaning the floor in our hospital. And it turned out she has got supraventricular tachycardia. So, of course, I worked in emergency medicine for years and years as a registrar. So, of course, that's a very easy case to sort out in theory. So we transferred the patient onto a stretcher, applied the monitor, and so on and so on. And there were two nurses and a healthcare professional on site. And I asked for help in cannulation. No one knew how to cannulate. I asked for help with blood sampling. No one knew how to do the blood sampling. I asked for help to do the bloods, to measure the bloods with our iStat, which is a relatively straightforward process. No one knew how to do that. Then the potassium came back. I measured all of this. The potassium came back as 2.8. So I asked for IV potassium. No one knew where it was. And the IV potassium. And then after that, I asked for an ECG machine. No one knew where the ECG machine was, so I had to go around and then look for the ECG machine. And then after that, I done the ECG, and I asked for adenosine. No one knew where it was. Just as a surprise. So basically, there was a series of never events in this case scenario. So I decided to carry out an audit with my very good colleague, Dr. Mustafa Afiz. If I could ask for the next slide, please. Yes. So may I ask you that by using the React button, just to make it a little bit interactive, would you be so kind just to raise your hand if you open the ALS or PLS book in between exams? The React button, just to raise your hands. 1, 2, 3. So not too many. Yes, exactly. That's the point. So for us, okay, 4 out of 59 people, 5, 6, 7. Yeah. So basically 8. Okay, we stopped at 8. So it's basically really the idea. The nursing staff and the healthcare professionals, they have an ILS teaching every year. So they replied the same thing. I presented this audit and the shocking findings, and they actually replied the same thing, that they want to pass that exam. After the exam is passed, no one opens that book. And as you know, basically the healthcare providers, they get de-skilled over time. So basically what I was trying to do and what Mustafa was trying to do, we wanted to be smart. And we identified critical. We were trying to identify critical points of uncertainty with practical resuscitation among healthcare professionals, and to raise the awareness of the importance of knowing and practicing resuscitation guidelines due to procedures, and because they get de-skilled over time as a natural process. So it's natural to happen to make the learning process and BLS ALS guidelines less stressful, and to discuss uncertainties in a friendly environment, because when a doctor comes with a questionnaire, everyone gets worried. So what we decided, we had a resus huddle every morning between 8:15 and 8:30, and the doctor basically prepares with one question from the from the Resuscitation Council website. So it's evidence-based, and then basically he teaches on those days. But first of all, I will start with the audit, just to make sure that you are aware of the findings. And then after that, we were planning to implement the change where problems were identified. If you can just to give me the next slide. So the methodology, we carried out an audit for two different single choice questionnaires were handed out randomly. 5 questions were concerning critical points of the BLS, ALS, research guidelines, peri-arrest and cardiac arrest algorithm, structured into sections: airway breathing, chest compression, drugs, safe defibrillation, and ABCD assessment. And we try to we identify the weak areas. These were simple questions. For example, how do you choose the length of the nasopharyngeal tube? I think everyone should know this. Or what is the rate, the depth, and of the chest compressions, and so on. And then we identified the weak areas, and these teaching sessions were carried out to the hospital staff in 2 to 5 minutes, because we had to be like we consider that it's it's a busy environment. No one wants a lengthy teaching. This is the start of the day, so it has to be quick and effective. So we did the teaching for 3 months between September 2025 and November 2025, and then we carried out a second audit cycle, basically with the same questions, and then after that we measured the impact. We try to keep the healthcare professional seniority distribution similar, because of course if you have got like 40 consultants and one nurse in one audit, and then next time you have 40 nurses of and a combination of nurses and HCPs, HCAs, sorry, in the second audit, of course they are not comparable. So in order to make it comparable, you have to everything must be kept the same as much as possible. And then we ask the satisfaction question afterwards as well. If I could ask for the next slide. Yeah, so this is the distribution of the healthcare professionals in the first cycle. As you can see, 40 people were asked. Mainly 75% were registered nurses, and 50% of senior nurses. A couple of doctors we could manage to ask, and the consultants are representing themselves as well as the HCAs. If I could ask for the next slide. And this is the outcome. And I think these were simple questions. So airway management, head tilt, chin lift in a unconscious patient to stop upper airway obstruction, or just to intervene until definitive airway is coming, or chest compressions. What is the rate, the depth, drugs? What is the dose of adrenaline? How does it look like? And so on, defibrillation, how do you switch between synchronous and asynchronous mode, and what is the ABCD rule, and how do you use it in the patient assessment? And I think the results are speaking for themselves. Half of the healthcare professionals were not able to answer these simple questions. We are very good, although so basically they were relying on the doctor. When I mentioned that particular case, they were relying on the doctor for every every single step: inserting a cannula, do the airway management, take the blood, measure the blood, bring the ECG machine, put the ECG. So they were relying on the doctors, and I think as a doctor in a hospital, you must be aware of that your healthcare staff maybe has the same level of knowledge, and if something goes wrong, and we are going to get we are having these kind of scenarios more often, because the private hospitals, they accept any of course more and more NHS contracts, and we have got more patients with more comorbidities, so you are going to see more unwell patients, and your staff may have the same level of knowledge on the ALS guidelines. So I would encourage you to kind of do something similar and teach them. These simple teachings may make a difference. I will show you the next slide. So the second audit cycle was carried out with 38 healthcare professionals, so the sample is representative statistically. Also, the distribution is kind of same. The doctors have fallen, unfortunately. Consultants are the last man standing. So basically, the results must be comparable. In other words, if I could have the next slide, please. Here we go. So we can see a massive improvement, almost doubled. The positive answers, the correct answers are almost doubled. So this is how effective a 2 minutes teaching is during the research huddle, because everyone is there and you want to convey a significant message with regards to your guidelines. I'm not saying everyone is going to be an ELS instructor after all of this, but it doesn't really matter who gives you the correct dose of adrenaline, the correct ampule. Actually, the dose is the same. So of course, the dose is the same. So you've got 1 milligram in the small ampule, and you've got 1 milligram or in the 10 mils ampule as well. However, when you give the small 1 milligram to, as you know, to a patient who doesn't have a circulation, it's never going to get to the heart. You need to have volume to push it up all the way to the right atrium. So basically, it doesn't really matter who brings you the potassium, as long as you or who switches the synchronous mode when it's needed. The main message of this is just a quick teaching, which is targeted, can save lives. Because if we increase the knowledge of these healthcare professionals of the ELS guidelines, they are going to be more time effective, and we know that time is neuron cells. Time equals to neuron cells, because you have got 5 minutes until neuron cell becomes, due to hypoxia, the functioning gets impaired. And the next slide, please. So also, when you appear in front of nurses with a questionnaire in the morning, you may be afraid of not being appreciated, and you may be afraid of being rejected. But I can reassure you, 76% of the responders, they said they needed this knowledge. And they felt more comfortable after discussing all of this with them. They felt more comfortable, more knowledgeable after these teaching sessions. And it's just, it's just a quick, simple message focusing on the ABCDE guideline, ABCD rule and the research guidelines. The new guidelines, of course, have come out since in 2025. These were carried out on the 2021 guidelines, but it doesn't really make a massive difference with regards to the message. Next slide, please. Yes. So after reviewing our aims and objectives, have we been specific? Yes, because we identified problems which are very relevant to our job. Were they measurable? Yes, because we measure them against established guidelines. Were they achievable? Yes, because they were like quick and effective teaching sessions and a quick questionnaire on the huddles, so they were achievable. Were they relevant? Of course, they are relevant. We work in a hospital where peri-arrest situations occur every week now, almost. And they have you been time bound? Yes, because everything will happen on a timely manner. Our aim was to identify critical points of uncertainty in practical resuscitation practices among hospital HCPs, and to raise awareness of the importance of knowing and practicing resuscitation guidelines due to providers get de-skilled over time, and to make the learning process of BLS and DLS guidelines less stressful and discuss uncertainties in a friendly, controlled environment in the morning, as opposed to the acute situations when it's too late. And we wanted to implement change in the practice where problems were identified, and we have done that. So we have achieved our aims and objectives, in other words. Next slide. So yeah, there have been a few little arrows here. Yeah. Yes. 1, 2, 3, breathe. Yes, he's that Jim. Thank you very much for your attention and for your hard work.
Yeah, Bertie, thank you very much. Very interesting how 2 minutes, maybe at the 10 to 10 or the recess huddle in the morning can make such a difference, isn't it?
Yes.
And I
And
think
actually,
Marius commented on it. Marius Mantella said that nursing staff would expect the RD to take all the responsibility. And why
well,
not? Why
yes.
not look at their knowledge, before? And also a good reminder that the 2025 guidance now is out. So a very, very good idea on the audit, because all of us needs to update our knowledge. I wonder if I can ask you maybe just how did you go about with the hospital to explain to the hospital how the audit is going to be conducted? And maybe any tips for our doctors that would like to do it themselves?
Yes. So basically, we have had, so unfortunately, we have had a few incidents, and this gave me the grounds to to inquire certain things. And basically, the main concern was, as I mentioned, very early in my presentation, that it's impossible for a resident doctor to carry out all of these procedures and to show how insert nasopharyngeal tube and so on. It is not really practical, and more than that, it's unsafe. So thankfully, we have a very good relationship with the hospital management, and I contacted them and I explained the situation. And since then, they have implemented multiple points. For example, we have got a new ECG machine, so we don't have to look for the ECG machine anymore, and things like that. So I think as long as we are constructive and we are open rather than being judgmental, they are very keen to cooperate, and thankfully in my hospital, they are very constructive as well. So we established a very good relationship, and they listened to my concerns, and we could carry it. And actually, I showed them actually they appreciated it very much, because the independent resuscitation scenario initially showed that, for example, healthcare professionals, they don't know how to give adrenaline. It was in June. In December 2025, we had another scenario, and that specific, there were problems identified, of course, that there will always be, but this specific topic was carried out with 100% excellence. So I provided them evidence that what we are doing is actually helpful, and they feeded it back up to the corporate level, and they were appreciating it very much. So I think open conversations and constructive approach will help. I think if the doctor provides evidence that something is not right, and the doctor asks for kind of help in establishing a good work relationship with nurses, because at the end of the day, this is very frustrating. So this is very frustrating because we want our patients to leave the hospital in one piece, but we can't do everything. So they need to understand it's a teamwork, and thankfully they did understand.
Yeah, absolutely. And Grace is asking, how do we handle communication issues during recess? And maybe an audit can show that there is, some work to be done on communication, and maybe that 2 minute session before, the work done long before the resuscitation could well be worth our while. So, Bertie, thank you very, very much. And it was for me absolutely a privilege to see you in 2009, and in the middle somewhere you've got your PhD as well. So,
Thank you very much.
absolutely fantastic, an example of lifelong learning.
Thank
Now,
you
I'm
very
going
much,
to
Dr.
ask that we take a break now. We're going to restart. I'm going to keep the event open because we are recording it. We're going to keep the event open. And then we're going to start at 10 past 11 with Dr. Nanji talking to us about early sepsis. So please make sure that you get something to drink, maybe a bit of tea or coffee, and I'll see you at 10 past 11 and we will resume. So please don't log off. You can just keep it as it is so that we can keep recording the session. Enjoy your tea and coffee. Oh, thank you very much and welcome back after the break. Erika, I'm happy for you to load the slides for Dr. Nanji. And Dr. Nanji, very, very welcome. Joining us today with the topic early sepsis and recognition and management in the intensive care unit. Dr. Nanji, if you can switch on your camera and just introduce yourself, that'll be fantastic.
Good morning. My name is Darlington Naji, and I joined NES about 13 months ago, and it's been amazing. Been working with this articulated and highly organized agency. I shall give them their flowers. I've been in intensive care for more than half a decade, and today I'm going to talk about early sepsis recognition and management in intensive care units. So to begin with, I'll just paint this scenario. You're a doctor working in one of our hospital sites. I actually work in intensive care unit of Manu Northfield Hospital, Oxford. So you're a doctor working in one of our Northfield hospital sites or any of our clients' hospitals, and you had a patient that did a HOLIP surgery 2 days ago, and the nurse came and met you and said that this patient suddenly became confused. Heart rate is 105 beats per minute. Temperature is 39.5. Blood pressure is 80/50. The nurse goes on to ask you, doctor, could it be sepsis? When you check at the lactate is 4.5. At this point, nothing dramatic has happened. The patient is still in the ward. Your action in the next 60 minutes determines the prognosis of this patient or whether this patient is going to survive. That brings me to the topic I earlier introduced to us, early sepsis recognition and management in intensive care units. Next slide. So we are going to run down in the next 10 to 15 minutes. We are going to be looking at this objective. We are going to understand the definition of sepsis, understand the burden of sepsis, septic shock, septic pathophysiology, and how to recognize sepsis even in the ward and intensive care units. Sepsis screening tools, how to source identification, go to the golden hour and management, and what is being done in ICU. Next page. Next slide. So, looking at the definition of sepsis, over the years, there have been three definitions of sepsis. The one defined in 1991 and the one defined in 2001, and the earliest one, the one that defined in 2016. Actually, that's 2016, but the process to make it defined started in 2013. So sepsis 1 and sepsis 2 try to overdiagnose sepsis in the sense that they were saying that sepsis is infection with severe inflammatory response syndrome like pyrexia, tachypneic, tachycardic. But in sepsis 3 criteria, which is the modern definition of sepsis, it goes on to say that sepsis is a life-threatening organ dysfunction caused by dysregulated host immune response to infection. It further breaks it down to say for sepsis to come, there must be infection, whether suspected or confirmed, and there must be organ dysfunction. And how do we know about this organ dysfunction? We know about this organ dysfunction by using some criteria like the SOFA criteria, which is sequential organ failure assessment. I will break it down further as we go to the other slides. Then just a recap about the risk factors of sepsis. Risk factors of sepsis could be age, it could be people above 65, people less than 1 year. It could be chronic diseases like diabetes, immunosuppression. It could be patients on oncology patients, HIV patients. It could also be due to invasive procedures, which in ICU, invasive procedures is done basically every day. Patients can be on catheter, can be on high flow nasal oxygen, can be on all sorts of urinary catheter, ventilated. And those patients are prone to sepsis if those things continue to stay in their body for a long time. Long hospitalization in the ward or in ICU, gene polymorphisms, racial and ethnic minorities, especially in poor resource countries where they don't have sufficient amounts of fundings. Next slide. So I'm not going to bore you with figures about the burden of sepsis, but it's good to know that in the UK, 48,000 people die annually due to sepsis, and 25% of these could be prevented. And worldwide, in 2017, World Health Organization said that 49 million cases of sepsis were recorded. Next slide. Okay, we are going to talk about the pathophysiology of sepsis and understanding septic shock. I just want to paint this scenario. Imagine there was a fire incident in your kitchen and you call the fire brigade. They use water to quench the fire. Instead of them concentrating in the kitchen, they end up flooding the parlor, flooding everywhere where there is no fire. They end up even flooding the neighborhood. And this is actually what happens in sepsis. When the body is infected, the body tries to secrete cytokines that helps to fight this infection. But these cytokines, rather than fighting the infection alone, they end up fighting other vital organs. This happens when there is pathogen-associated molecular pattern system and damage-associated molecular pattern system. When they bind to the toll-like receptors, they also activate the intracellular pathways, which release these cytokines. And once these cytokines release, there's endothelial dysfunction, there is vasodilatation, there is endothelial leak, and there is tissue hypoxia, which subsequently leads to organ dysfunction. And we can see this when there's lack of oxygen in the brain, it causes confusion. When there's oxygen does not reach to the kidneys begin to shut down. There's hypercoagulations. There's all sorts of problems happen in sepsis. So next slide. So looking at the sepsis screening tools, over the years, there have been some screening tools identified to diagnose and manage sepsis. The one we are most comfortable is the National Early Warning Signs. We looked at the respiratory rate, the oxygen saturation, the temperature, the systolic blood pressure, and the mental response. I believe all of us have seen this and we use it in our hospitals and know when to activate if there is sepsis. Other ones is the quick sequential organ failure assessment, which uses 3 parameters: the systolic blood pressure less than or equal to 100, respiratory rates greater than or equal to 22, and altered mental status. And the one that we use basically intensive care in it is sequential organ failure assessment, SOFA criteria. If you look at the table, there are 6 major points listed here, which targeted at the 6 points, 6 organs attacked by sepsis. We have the respiration, the coagulation, the liver function, the cardiovascular, which is which causes hypertension. We have the GCS, which in the scenario I painted earlier, the patient was confused. We have the renal, when there's renal shutdown. Next slide. Next slide. Hello? Yeah. Can you just go back to the previous slide? Yeah. No. Go back a bit. Hello? Yes, go back. Okay, let's go. Yeah, yes, this slide. So using this criteria, if the dysfunction is no, the other slide, please. Hello? Hello? Okay, let's go. Oh yeah, this slide. So oh God. Okay, let's continue. So sepsis, golden hour, and management, which is the meat of this matter. And like I said, what you action in the next 1 hour determines whether this patient is going to survive the prognosis. So in the first 1 hour, you use the sepsis 6 bundles. You give oxygen if to keep this SpO2 greater than 94%. You administer antibiotics. You check the lactate level, which in this case we checked it was 4.5. You set up an intravenous fluid, and you monitor urine output, take sample for blood culture. Then within the 7 to 72 hours, you have to continue your volume resuscitation. You have to adjust your antibiotics because after 2 days, the culture is out because you look at what causes this infection. It could be gram-negative, it could be gram-positive organisms. Also, you try to adjust your ventilation if this patient is ventilated. In the next 73 hours, if the patient has responded, you try to remove unnecessary devices because too much devices, especially in the ward or in the ICU, can lead to this sepsis, can lead to gram-negative, gram-positive organisms, or even fungal organisms. You start winning your removing all unnecessary devices, winning your antibiotics. Next slide. So clinical recognition of sepsis in ICU. Like I said initially, we have sepsis 2 criteria, which is not used currently. We have the sepsis 3 criteria. So this pattern shows us when a sepsis becomes septic shock. Like in using sepsis 3, there must be an organ failure. And once there's organ dysfunction and infection, either confirmed or suspected, then that's sepsis. With your new score, with your SOFA criteria or quick sequential organ failure assessment, you should be able to know there's an organ dysfunction. Then you talk about septic shock. In septic shock, there's refractory hypotension. You've been given IV fluid. This patient is not responding to IV fluid. You start the patient on inotropes. But there's a catch to this. In people with heart failure, you don't continue giving 30 ml per kg bolus of IV fluid because you are worsening the heart failure, it's pulmonary edema. So septic shock, if it means that when there's refractory hypotension, means arterial map not constantly below 65 milligram per mercury. Next slide. So we are looking at the sepsis monitoring and supportive measures. Like sepsis is a multiple disciplinary approach in the sense that most organs in the body are affected. The kidneys, you involve nephrologists, the coagulation, you involve the hematologist, even the endocrine. If it's affected, you must inform the endocrinologist. And continuous monitoring of this patient. In ICU, we monitor these patients, we use the new score, we monitor the lactate, we even use the procalcitonin level, and just to monitor this patient. And in the first 24 hours of them being in ICU, we use what is called Apache score to monitor them. Nurses are quite essential in the sense that they are already on site to see and monitor these patients. Rehabilitation processes like the occupational therapy, because sepsis might take you off from work, it might affect the brain, so they need rehabilitation services. You adjust your antibiotics, you consult with microbiologists. ICU organ support, like I said, using ventilators, instituting proper nutrition, turning these patients every 2 hours just to prevent sepsis, removing unnecessary devices, introducing inotropes. Ones commonly used here, have been here for 13 months. The more commonly used here is metramine, or adrenaline. So these are basically how we monitor and support patients with sepsis. Next slide. So before I conclude, look, there are some challenges of potential challenges and interventions that can be done. I'm not going to read the slide, but one of the challenges is delayed of institution of treatment. And how are we going to eradicate this challenge? By educating the patient. They should be able to know the signs of this sepsis. Another challenge is utilizing and adhering to the survivor sepsis guideline. In our hospital here in Oxford, all the parts of this hospital is being tested with sepsis protocol. so that everybody will know when to act par. If you have a colleague feeling unwell, confused, you have to act par, because your action in the next 1 hour determines if this patient is going to survive. Next slide. So the key home take message from this 15 minutes discussion is: recognize sepsis early, act quickly to save life, always use sepsis criteria, use quick sequential organ failure assessment and SOFA criteria to pick up sepsis, and involve the intensive care unit on time, involve the multiple disciplinary team, the infectious disease, the microbiologist, the nephrologist, and also we should try to adhere to the protocols. Early recognition, start treatment, reduces hospital stays and the cost of treatment, and generally reduce the cost of healthcare burden. Next slide. Thank you for listening.
Dr. Ndanji, thank you very, very much. Very interesting. I wonder if I can ask you with your react button to at least acknowledge all the work and time going into this. We had one, Marius Ventella said that he have seen that a large number of localized infections, there was no difference between that and sepsis, or very difficult to make that that diagnosis between the two. And that there is, he also reminded us that there is nice guidance out on sepsis and antibiotic stewardships. But I was wondering, Dr. Darlington, in your setup specifically, was there anything that you had to do with the hospital to convince them to do the audit? Or what was your communication with the hospital to do the audit there?
Sorry, I didn't get the question. To do the audit of sepsis or?
Yes, what was your communication with the hospital just to steer other doctors if they want to do the same?
Yeah, they'll be happy to do it. Yeah, I think I'll speak to them, and the hospital is quite supportive, and they'll be happy to assist resident doctor in any audit. It's just that I've been taking up the audits, and I will relate to them. Yeah, they are very supportive.
Yeah, so very, very interesting, and I think sepsis one of the challenges in healthcare. We've put a lot of emphasis in the last 10, 15 years on sepsis, and it is good to have that at the forefront of your dealings with patients. Certainly from a medico-legal point of view, you know, it is rather better to be proactive with sepsis than reactive, isn't it? With all the guidance out there. But Arlington, thank you very, very much for taking time and presenting with us today. Absolutely fantastic. Thank you. I would now like to introduce Dr. Pujari. Dr. Pujari, happy for you to switch on your camera, just for you to do a quick introduction. And this is all going to be about the adverse side effects of Nefupam on post-surgical patients. Good morning, Dr. Pujari.
Good morning. Thank you.
Right, I wonder if you can, there you are, fantastic. So happy for you to introduce yourself, and how long have you been with NES?
Thank you very much, Drogsky. So very good morning to everybody. Thank you for joining us and giving a massive support. I really appreciate that. And thank you for the NES whole team for giving this platform to show ourselves. So my name is Dr. Mohan Pujari. I'm based on the Lincoln, and I'm currently working in the Lincoln Circle Health Group. So I've been with the NES since June 2024. So it's almost 21 months. Right. So that's all, basically my introduction. Let's.
Fantastic, and happy to listen to you.
Yeah, thank you. Right. So basically, it's regarding one of the main pain medication that we use in our hospitals, especially in our private care. So I do understand that everybody knows about the Nefupam, one of the medications that we use, and I'm talking about the uses and side effects that has, which I personally have absorbed during my hospital practice in these 21 months. So next slide, please. So basically, just the introduction. So nifedipine hydrochloride, or central acting, as we know that it's non-opiate basic, based analgesic, and its composition is C17H19 and NO hydrochloric acid. Chemical name is 5-methyl 1-phenyl 3,4,5,6 tetrahydro 1 hydrogen 2,5-benzoxazine hydrochloride. So next slide, please. So basically, we use this nifedipine. Usually, the doses in our hospital is 30 or 60 milligrams. So it can be used up to 90 milligrams 3 times a day, as per the BNF. But mostly, in our practice, we use the oral form mostly in our hospital. However, intravenous and intramuscular forms are also available. Next slide. Yeah. So here I'm talking about the mechanism of action. So I've grouped it in 3 different subgroups so that it can be a bit more easier to understand. So basically, what centrally acting and the mechanism of action of the nifedipine is basically, it is known as the triple neurotransmitter reuptake inhibitors. So the short form is SANRI. It's S stands for serotonin, N stands for noradrenaline, and D stands for dopamine. So basically, they are these neurotransmitters are inhibited, or the reuptake of the neurotransmitters of these neurotransmitters are inhibited. So which gives the pain relief. All right. Next slide. The another mechanism of action, obviously, is the ion channel blockade. So in the neurosynaptic junctions as well, in most of the cases, the sodium channel and the calcium channels, they are blocked. That's how it acts centrally, and thus it contributes to the analgesic and potential neuroprotective properties. Next slide, please. So the third one of the mechanism of action is it basically acts by pain receptors in the central nervous system. That's how, and apart from that, as we all know, it's not it doesn't act on the opioid receptors. So it just simply blocks the pain receptors in the nervous system. Next slide, please. So the most common side effects that we majority of the doctors, they might have seen during the hospital practice, because of the nifedipine, it could be nausea. Patient might be complaining of vomiting as well as dry mouth. Especially the dry mouth is abundantly found in most of the patients, and dizziness and lightheadedness, which are actually covered by other stuff, because the patient is always had either the spinal or general anesthesia after the surgery. We hardly notice that it can be caused by the nifedipine use as well. So another common side effect is the urinary retention. Maybe it's not really common in the practice, but like I've seen like a urine retention in most of the patient while using the nifedipine, especially like not only male but also in the female patients. So I was previously I was thinking like the urinary retention, it was caused by the prostate issue in the male, but later on I found that it's in the female as well. So and it is usually caused by the nifedipine, as I've searched on the internet. Obviously, that the one of the common side effects of the nifedipine, it's the urinary retention as well. And after all these, another common side effect is nervousness and tremor. So basically, nifedipine also causes nervousness as well as tremor. Next slide, please. So some of the less common side effects, like that can be coincidence as well. One of the less common side effects is confusion. Since we are also using more opiate basis medications in our hospitals, so we we can relate that opiates can cause confusion and other symptoms that has been other side effects that has been enlisted over here. So opiates can cause all of them as well. But during my practice, when nefpam was used, these were the side effects that were more often present, especially the hallucination. Because patient, as soon as we use the nefpam higher doses, especially the 60 milligrams, most of the patients, they were complaining of uh, hallucination, especially insects or spiders walking around the walls or something like that. That has been caused by the nefapam, obviously. So blurred of vision. Well, in my practice, I haven't seen any blurred vision unless and until just one patient who came back with blurred vision months, but it was few weeks ago. We didn't really know that it was caused by the nefapam or anything else, but we are following up with this patient. So in the meanwhile, yeah, I have put the patient as the potential criteria for the common side, less common side effect of the nefapam. So angioedema, I haven't found any of the patients that have had angioedema in my practice. Yeah, diarrhea I did have, and syncope I did have, and seizure not found in my clinical practice. Yeah. Next slide, please. So nefpam, yeah, obviously we need to be cautious of using the medications while using other medications at the same point. So one of few of the medication that we need to be cautious with while using the nefpam is antidepressant group called monoamine oxidase inhibitors, such as phenelzine, isocarbazole. And another one we need to be taking care of is tricyclic antidepressant, such as amitriptyline, because I see many of the patients that are using amitriptyline for many different regions in the UK, and especially while they come to the hospital. So we need to be more cautious while using the nefapam if the patient is using amitriptyline. And another one is antihistamine, because patient can get the antihistamine tablets over the counter. Patient might be using those, and I found in the clinical practice, some of the patients, they don't really tell that they have been using the over the counter medication antihistamines. So yeah, nefpam can really cause exacerbate the side effect of the antihistamine, that is dry mouth and sleepiness, and it really, really worse. So next slide, please. So the absolute contraindications of the use of the nefapam is convulsive disorder and the myocardial infarction as per the BNF. Next slide, please. Yeah, so I've already actually discussed about what I have seen in my practice. So most common side effects that I have personally found in my practice is dry mouth. Like almost all the patients who had nefapam during the post-op day and post-op day ones, they almost all of them had the dry mouth and dizziness. Yes. So basically, nausea less common than opiates because it's not my belief, but nausea, it is basically one of the common side effects of the opiates, but nefapam has less common side effects in my findings in my clinical practice. So yeah, urinary retention. I've already told you about urinary retention. So I have found many of the urinary retention patients that those who were using the nefapam. So I'm still digging into this matter. Yeah, next slide, please. So it's the less common side effects in my clinical practice findings. Yeah, confusion, definitely not everybody was confused after the use of nefapam, but yeah, I did found few confusion, but I did found hallucination in 3 patients. Yeah, so it's right after use of the because patient were staying like 1 or 2 nights. Day ones and dangerous patient, they were using the nefapam, and I found that they were having hallucination. 3 of them were hallucinating than and obviously with the opiates, I didn't found any. So basically, I'm suspecting because of the nefapam. And as I've told you, like a few weeks back, I found a patient with who came with the complaint in the actually he came for the physiotherapy, but he was complaining of the blurred vision, but he never had any blurred vision before the surgery, which appeared after the surgery. We have sent the patient to the ophthalmology review, and we are following up with that patient. And another indirect thing that I found until now. I'm not pretty much sure. I couldn't find any data on the internet or anywhere in the papers that nifapam can cause the hypernatremia. But from my clinical practice, I've what I have found is like there is indirect relation with the hypernatremia due to the urinary retention, most potentially, because as we all know that urinary retention can cause the hyponatremia. So I've found in my practice there were 4 patients who had hyponatremia and it was not really improving at all. And I have a good chat with one of my colleagues from another hospital. So he was telling that they often use the nefapam as well, and he was struggling with the hyponatremia. I wouldn't suggested him to like do my method, but like I've just tried on my own. So I have talked with my consultants as well. So in my hospital, nefapam these days is rarely used, but still we are trying to, whoever has been taking the nefapam, we are trying to check on them. So nefapam was stopped and the patients were like the sodium levels, they were improving as well. So one of the examples is a real patient. So it's not just example. In my practice, one of the recent finding, one of the joint patient replacement done was she was taking nefapam 60 milligrams three times a day, and on the post-op day it was 127. But she was definitely not having any of the symptoms due to the hyponatremia. So she was sent home with slow sodium and yeah, basically with the nefapam 60 milligram, 30 to 60 milligrams TDS, but she was taking the higher doses. But uh, since we had a lot of issue with the low sodium, the hospital and we have set up a policy that we are going to check the blood sample serum sodium level for after 48 hours after they go home. If somebody has gone, if somebody's blood report showed that there is slight bit of hyponatremia, even if it's 131 or 32, we're calling them back after 48 hours for another blood sampling test. So what I found is like after 48 hours on post-op day 3, the sodium was still 125. It was creeping downward, but since it was not a drastic change, so the patient didn't have any symptoms regarding the hyponatremia. And yeah, so we had a chat with the patient, and definitely she was taking nefapam. I had to have stopped the nefapam, and since she was already on the slow sodium, I didn't intervene much. But the next 48 hours, we reviewed the blood sample again. Obviously, I asked her not to take nefapam, to take other alternatives that we had given to the patient, and blood reviews obviously showed that the sodium was 136. So I'm not claiming the thing that it could be definitely because of the nefapam, but we are still in the progress that we're checking on the patient who's having the hyponatremia and also taking the nefapam alongside. So basically, I'm just trying to make some audit regarding this. I've not made the official audit until now, but I'm really open to whoever wants to join in if somebody is really using the nefapam. Next slide, please. So the conclusion basically is nefapam is really, really good medication for centrally acting. I mean, for the pain relief because it's centrally acting and it controls the pain like very good. Uh, Apart from like any other medications that we have found in the hospital. But however, it can really invite unwanted problems, especially in the elderly patients, like especially above 70 years. So it should be used really wisely. from my point of view. That's all. Next slide. Thank you very much. Any questions?
Dr. Pujari, thank you very much. This is very interesting. I wonder if we can use the react button. There's a few reactions coming up already. But
Thank
very
you.
interesting, the connection with the urinary retention and specifically the hyponatremia. We had a session earlier. You know, the clinician in us will always wonder if there is a connection, but it's not yet in the books.
Yes.
So who knows? You know, maybe it could come from the resident doctors. Now, Grace asked, with caution using antihistamines, will that be specifically for sedating antihistamines or for all antihistamines?
It was found just all antihistamines, not just sedating, but with the cetirizine as well.
Okay, very, very interesting. And then we had Marius that reminded us that it's not good to use that with known epileptic patients, which is certainly true. And then Grace asked again in conclusion, for individualized patients, what would the approach in use be? Because some patients can't tolerate opiates or NSAIDs, what is the next option? So if we're not going to use Nefupam, what would you suggest?
Thank you, Grace, for the brilliant question. It's yeah, personally saying, I mean, having that said that Nefupam can cause really dramatic side effects with drop in hypernatremia in few of the patient. Yeah, Nefupam can be used. I've like just in an emergency condition, I've started using the Nefupam just 30 milligrams. That is the smallest dose possible in our practice. So I've used that. Since if somebody cannot use the NSAIDs as well as allergic to opiates, like Nefupam low dose can really help. It's just that a higher dose of 60 milligrams and using quite often is really causing mess in the patient. So maybe I would suggest like if Nefupam is the only option, try using the just 30 milligrams and look for any signs and symptoms before you proceed for the next dose.
Yeah, very, very interesting. So thank you very much, Dr. Pujari.
Thank
it
you.
was absolute a pleasure listening to you and just to have some insights, you know, on the post-operative use of medications that we use on a daily basis. And Emmanuel is also saying there it is definitely safer to use the 30 milligrams.
Yes.
So I think we will leave our audience with that specific message: go low and slow. With Nefupam, look out for urinary retention and maybe connect hyponatremia to that. So very, very interesting.
Yes.
Thank you very, very much. We're going to move on. There is a few questions, Dr. Pujari, if you want to answer that directly in the chat.
Sure.
If you want to. But I
Yeah,
am
they're
going
just
to...
they're
Yes,
not
sorry?
questions. Yeah, they are just saying the same thing, I guess. People have
Yeah. But if you want to go back to the chat and answer it from there, it would be good. But thank you very, very much.
Thank you very much. Thank you, everybody.
You're more than welcome. I've got the privilege now to welcome Dr. Emeka Okolo. We're going to put your slides on in the meantime. Now, Dr. Okolo is going to talk to us about the steps that we actually need to take for a clinical audit. We talked about audit this morning, case studies, very interesting diagnostics of sepsis in ICU, and also then the use of Nefupam. And we're going to end the afternoon or the morning session with a case study as well. But Dr. Okolo, if you want to switch on your camera and introduce yourself, that'll be absolutely fantastic.
Thank you so much. I don't know if you can see me.
We can see you, fantastic, and the sound is good.
Thank you. My name is Dr. Emeka Okolo. I'm a resident doctor working in the Park Hospital, one of the Circle hospitals in Nottingham. I've been asked to speak on this topic because just a little background before we go into it. It was last year after my appraisals, the appraisee my appraiser said, advised that since I'll be getting closer to my revalidation, which will be next year, I should consider doing a quality improvement activity. So it happened to be that around that same time, I noticed there was a spike. This was late last year, 2025. There was a little spike in infection. I was seeing quite a number of cases in the hospital post-op patients, and so I thought, why don't I work on this and see how to improve on our documentation in the hospital, because there is a local standard already as a circle group, but I noticed that there were some lapses. So with nobody to help and with nowhere to turn to, I decided to conceptualize what I would be doing. So my which is currently going on. I'm at in the first cycle of my clinical audit, and it's basically about surgical site infection, early documentation, and early management protocols. So we are looking at doing 2 cycles between now and May, and seeing how we can improve on that. So, but that's not what we're talking about. I'll be talking about how I managed to get my clinical audit approved by the head office of the Circle Health Group. First slide, please. So yes, generally, like I said, I noticed the spike, and I was just wondering why we were having this. With clinical audit, with quality improvement activities, we are looking out for patients' safety. We are trying to improve the services that we render, and many times it makes our day-to-day work very easy, because when you have a standardized approach, or you are able to reinvigorate the staff to follow a standard approach, then you as the resident doctor, your colleague who is the second RMO, and the other nursing staff, even the ITU RMO, sometimes we all work together. It makes work very easy. Then I discovered that this would also help with portfolio building in the long term, because not only was my clinical audit approved, I was also approved to do a micro teaching section that will last for at least 3-4 months. Then I was also approved to speak to the Circle Health group, because now, because of the way it all happened, my topic was escalated to the Circle Health group. So I've been in talks with the head office management team, including their clinical leads, the director of clinical services at that level. Next slide, please. So yeah, let's start by the basics. So what is a clinical audit versus quality improvement activity versus a research? I will just speak plainly. I will not be going into the technical definitions of this term, but an audit is simply getting what you currently have as a standard in your local hospital. You may decide to do your audit based off of a standard in your local hospital or on a national standard. That should be your benchmark. When you have that, you compare it with what you're currently doing in the hospital, so which is the data collection. So that is what it is. Are we meeting up to the standard? Are you able to meet up to this standard? Check what you're doing. Is it rhyming with what you're doing with the general standard? Then you talk of QI. QI is basically you identify the problem and you want to improve on that problem. Say on the ward you identified you have deficiencies in prescription errors, you want to improve on that. And research is what is the truth behind what is being done. So it involves getting new knowledge, ethical approvals, usually much more detailed and much more difficult to carry out. So, but we are encouraged to do more of QIs and clinical audits. So, like I said, my experience on my own situation is more of QI/clinical audits. Next slide, please. Now, there are 7 steps that I discovered whilst I was, because it was a big challenge. I did not know who to turn to. First, I had a consultant who is an orthopedic consultant here in my hospital. We worked closely together, and I spoke to him about this. And he said, sure that why don't I carry on and see how I can do it as the audit lead. And I started going around and I discovered that there are this beautiful diagram I saw, I've just spoke about. So there's a set standard, which is the yellow mark, yellow arrow. So with this, the set standard that you have, you want to measure your current practice versus the set standard, which is the blue one. So you're comparing the results that you have and the standard. So for you to compare, you have to gather results. So that's the stage I'm currently at. I'm at the stage of gathering data in the first cycle. Then you go on to reflect, plan, and recommend changes. So they are already waiting for my recommendations, which will be in a couple. So in a couple of weeks, I'm trying to gather the information at the moment. Then when you have that data, after a recommendation of your recommendations, you can now do a re-audit. So it is now when you re-audit, it's like a circle, it keeps going around. When you re-audit, you compare it and you can be able to build on whatever you've done. Next slide, please. So the first step is identify the problem, why it matters. Because in my situation, like I said, I'm working alone, and I was able to reach out to my supervisory consultant. Then I discovered that the next step for me is to reach out to my director of clinical services. She is she's like a senior nurse in the hospital, but she's the director of the clinical service. So I approached her and I discussed my intentions and explained to her what I discovered and why I think this is important. The next step. Next slide, please. So yes, whilst I did that, identify the problem, why this matter, then I went on to searching in the trust, in the local hospital, what do we currently have so that we can define what the standard is. So I discovered that they had this booklet, which I have in my hand here. There's a little booklet that they have where we're supposed to fill out, but nobody was really doing that. Or they were doing it, but I've discovered that they've not been doing a lot of the data input so well. Next slide, please. So then I officially decided, okay, you choose your sponsor, choose your supervisor, choose your team. In this case, I did supervisor first because of the closeness I have with my supervisor. Usually, it should be you've identified the problem, you've done the standardization and criteria stage, then you reach out to supervisor. So then my team currently involves my ITU RMO, myself, and one of the nurses on the ward. So yeah, we are the three of us currently working on this audit. Next slide. So after that was done, I had to put together documentations. I wrote a proposal, including minimal viable project I could do. I wrote how long it would take, what I need. You have to put it as a package. I had to formulate my questionnaires. I had to formulate my data collection tools, my supposed proposal that I think would be. Because once you get all this together, you need to send it to the local audits or local audit team or the governance team in your hospital. They would look through it and will approve it. So mine took me about 2 to 3 weeks before I got approval. Next slide, please. So information governance would include anonymized data sets, secure data. So this is all part of gathering the documents. Information governance would require you to be careful with how you store the data. Right now in my room, I have loads and loads of patients folders. I have an agreement with the staff to make it all anonymized. My data collection tools, nothing can leak out because of previous issues, because of information governance issues. So you have to be sure that all these steps, you are following them. The next slide, please. Then you go into collection of the baseline data. Next slide. And once you've collected your data, I think the collection of data is quite the practical side of it that you see you started the audit. The next will now be what have you found after your data, what the changes you think you can implement, then recommend these changes to the director or to the leadership of the hospital and remeasure after a couple of weeks of implementation of your recommendations. You now remeasure what you have recommended. That would now be the second cycle. So a clinical audit is 2 cycles or more. So next slide. So usually, like I said, where do you start from? I think for this one, you need, because I was speaking to somebody about this after I heard that I was supposed to do an audit, and I discovered that I did not know where to start from. So you need to be able to pick a winning topic, a topic that is you can achieve in a short possible time. You're not trying to achieve big goals. You want to be able to achieve measurable goals. Choose a clear standard, choose a topic, make sure your standards are clear and that it exists. You could choose from the national guidelines, or you could choose from your local hospital. Then ensure that you can work within a short possible time so that you don't burn out. It's not a research that you need to work for so long, or it's not a clinical trial. So it's just a short period of completion. So you choose 6 to 12 weeks typically. Then examples of topic you can work on that I found that are easy to work on are something like surgical site infection documentation, VT prophylaxis, sepsis bundle completion, antibiotics documentation, discharge summary. So you can audit around these topics and you find it very, very interesting. Next slide, please. So to design your project, you design your project along these 5 lines. Next slide. So your aim is you're at level X. To increase your aim, which is X, from A% to B% by the end of the day. So for me, our period is between now and May. So by end of May, we want to see, and this will be end of the second cycle, we want to see how far we've come from now to then. Next slide. Next slide, please. Yeah. So you want to also choose your population. In my case, I limited my population to only those with suspected surgical site infection. I'm not choosing patients on the ward who had infection or prior. So when you limit your population, you are able to get a focus on what you want to do. The next slide. Now you have to measure what you actually want to study, because there are a lot of things to do in a clinical audit, but choose the outcome, what you want to achieve, the process, how you want to go about it, and balancing how or where. Like, take for instance, in my case, where do I want to start gathering the document from? I had the opportunity of reaching out to the pharmacists department, to the microbiology department, and to the dressing room. They have this list of patients they record anytime they see patients. So that was where I liaised with, and I got all the information I needed. So you choose all of this. Next slide. Intervention. So yes, the intervention will now be, okay, now that you've gotten this data set, you've analyzed the checklist, or you create a checklist of, yes, so this is my recommendation. It should follow a checklist pattern. 4, 5, 6 recommendations is fine. And in those recommendations, please also request that you're able to teach. Because when you carry out an audit, request from the approval team that you want to be able to teach your staff. The next slide. And when you teach your staff, you're able to, because you carried out this audit by yourself or with the aid of another colleague, you're able to move from baseline to intervention and to audit. You understand the full package and you're able to speak about it anywhere, anytime. Next slide, please. So yes, go. Just go and let the whole of this. Next slide, yeah. Good, thank you. So yes, that's it. So as I said, in my case, I noticed the recent rise in infection, review, post-op wound infection reviews across orthopedics, plastic surgery, general surgery, and I decided, what am I to do with this? I decided to audit the whole documentation and initial management steps. I chose my consultant, Mr. H.C. Mata, is an orthopedic consultant working in this hospital and also a consultant in Nottingham University Hospital. Then I moved from the director of clinical service to the head office approval. They escalated my proposal to the medical director of Circle Health, so he is aware of this. and the Chief Medical Director of Circle Health. They are waiting for my presentation, which would come after I'm done with this audit. So then, after they approve, they transfer me to the Clinical Innovation Board. Then my approval came to me back at the end of the 3rd week. Next slide, please. So yes, I think data collection, easy capture. You want to do things like a simple data screenshot and screenshot star. That is on one paper. This is all to make it easy to capture your data. So you could include things like date, specialty, procedure types, wound assessments. Was it documented? How was was an examination of the wound done? Was there any microbiology swabs taken? Yes or no? And many times in audit, you want to do yes or no question kind of format because it's an audit. Then follow-up plan, was it documented? You should remember that whilst you're collecting all this data, key thing is you want to anonymize everything and use what we call coded case IDs. So you will not write the patient's hospital number. You rather form code IDs for each of the patients you choose. Next slide, please. Yes, then, like I said, after your audits, you've gotten your 2 circles, then you would now do what we call, even between the first circle and the second circle, because you'll be doing teaching along the way. I find that I'm doing micro teaching along the way now. You do 10 to 15 minutes of micro teaching. Make sure that you print out, these are the documents I printed, I have already conceptualized, feedback forms, attendance log, then what my re-audit would look like that should last for a few weeks after we've given at least 2 to 4 weeks implementation gap of my recommendations. Next slide. So yeah, the evidence pack for higher specialty training. Yeah, because for me, I have an interest. So I divert a little by saying that I've just finished my master's in cosmetic medicine, and I hope to, along the line, maybe not this year, maybe not next year, because of course, the UK prioritization and everything happening in the country, you discover that as a medical person, you need to build portfolio. I discovered that I need to be able to do more of these audits. And so I've told myself that every year I want to be doing 1 or 2 clinical audits regardless. And it helps with higher specialty training eventually when you want to go into training. And you need things like your supervisor writing, recommending you, saying that yes, he supervised you. You will need in your teaching to form a teaching timetable, teaching attendance, feedback summary. Then you would also need to prepare for your QI reports, like in a circle in this diagram. And we call it plan, do, study, and act. It has to be in that manner. I also find that this will be helpful for my revalidation coming up next year. So all of this is like using one bird to kill 2 stones. You have to do an audit and make sure that you do it well and fine. Next slide, please. So yes, thank you. I round off by saying that a clinical audit, sometimes it may look like impossible in many private hospitals. I'll be clocking 3 years with the NES. I've loved every bit of the way. And I discovered that my eye only got open in January. And that was when I discovered that, oh my God, clinical audit is really interesting. It's something I can do. I have a very supportive team here in the Park Hospital, and they've been helpful so much in achieving this. So in case you need any advice, you need any help, you can always say hi or send me a message, and I'll be willing to help. Thank you.
Hi, Dr. Kolo. Thank you very much. It was certainly very interesting, and just to bring us back to the basics of the audit, isn't it? Because that's so many people ask, where do I start? And the 3 important questions is, what is frequent in my hospital? What is important right now, and can I measure it? And if you've got those 3 questions, even if you just start writing it out on a piece of paper, that'll be a very good start. And then talk to people around you in the hospital, isn't it? Is there something that they're already doing that you can maybe contribute first to, and then do your own audit? Now, I can see on the screen there is many reactions going on. So thank you very, very much for your presentation. and I look very much forward listening to your audit results coming out maybe next year. We will ask about some feedback once the recorded version has been seen as well. And it might be that we do this again or maybe more frequently. But thank you very much for your time. And again, I appreciate, it looks from here like a few slides, but there's hours and hours of work that is going into that. But thank you very, very much.
Thank you.
So that brings me to our last speaker of the day, Dr. Okokon Emmanuel. And this is all about a case study of post-operative complications about subcutaneous emphysemas. We certainly had a very interesting array of topics throughout the day. So Emmanuel, happy for you to switch on your camera and if you want to introduce yourself.
Hello, everyone. Good afternoon. Good afternoon. I've learned so much while I'm at work right now, so I kept having to dash in and out. But I'm quite glad now, in light of what everyone has done, that this is kind of the last presentation, because it's not very cumbersome or it's not overwhelming in any way. I just want to use this opportunity to thank Dr. Droske, just to say thank you so much for this opportunity to for us to continue our medical education and to gain CPD points from teaching scenarios and seminar topics. It's really commendable.
It is an absolute pleasure, and
Thank you.
after your presentation, we will provide the link for the certificates. But thank you very, very much indeed. We're looking forward listening to you.
All right. So today I will be speaking on subcutaneous emphysema. It's a post-op complication that I observed, I think, in January, which was quite odd because it followed a myomectomy, a robotic assisted myomectomy procedure, as opposed to what we are commonly used to, which is thoracic surgeries. So I just wanted to share this with the team. A lot of us might not find this very relatable because it's very rare. And usually it's not an emergency per se. It's just something that we need to know about, because many times it passes on its own. But then, with the rising rising cases of robotic procedures, we're going to have more and more incidences of these rare complications. Yes, next slide, please. So we'll be discussing on using this contents, introduction, patient summary, being a case review, or just going to discuss clinical presentation, pathophysiology, just a little of everything. I just want us to know that this isn't exhaustive in any way. We're told to prepare for 20 minutes. So I'm trying to keep everything within that time frame. And I'm sure we're all really exhausted by now. So yeah, let's move on. Introduction, please. So subcutaneous emphysema is a recognized but relatively uncommon complication of laparoscopic and robotic surgeries. Primarily, it's due to the use of CO2, which is insufflated into the abdomen, in this case, actually, just to create room for the surgeon to do his work. The reported incidence, as we see here, is 0.4 to 2%, which shows you how rare it usually is. But then it goes up to about 6.3% in thoracic surgeries. And also often it's benign, but it carries significant clinical significance. It carries an important significance there. The key concern here I have to reiterate is that it may progress to a serious condition, right? it may progress to a pneumothorax or a pneumomediastinum, which we're aware of. That's when there's air, constricting the lungs, preventing, the expansile efforts of breathing. The case basically that we're discussing here is just to reiterate early recognition, appropriate clinical assessments and escalation, as well as safe conservative management where the patient is stable. Next slide, please. So for the patient summary, so this patient was a 50-year-old female. BMI was normal, 22.9. She was to undergo an elective robotic assisted myomectomy, where 13 fibroids were removed. The goal of the procedure was to preserve fertility. So she had come in with complaints of, heavy menstrual bleeding and pressure symptoms. And so this was the best way to go. And in the course of that, her medical background, by the way, was just quite light asthma. She had a history of asthma. This is significant because, as we will get to it, it's, if there is an acute exacerbation, this could actually also very rarely, but possibly lead to a pneumothorax, which could, go the other way and cause some subcutaneous emphysema and things like that. So, but in this case, there was no acute exacerbation. So she had a background of asthma and penicillin allergy, evidenced by a rash. Pre-op observations and blood tests were all within normal limits. Yeah, making her a relatively low-risk surgical candidate. Next slide, please. For the clinical presentation, this had started actually on day 0, but it wasn't as obvious as the first day post-op. So I was called to see this patient, and she had developed a left-sided, her orbit, the whole of her left eye was swollen, and the cheek on that side also, the neck was swollen, and so on. Those were the obvious parts of the body because the rest was covered. And she had developed that swelling. It was thought initially by the anesthetist to be a simple post-operative edema, right? So we just thought that, okay, there was really nothing to do at that point. But when the nurse called my attention to it, I approached the patient. I then asked a few questions. She had said that there was no shortness of breath, there was no dysphagia, no change in voice, there was no restriction to the airway, because that swelling initially bothered me that, it might compromise the airway. But for that, palpation, there was the feeling of the crepitus, palpable crepitus over the eye, the face, the temple area, the neck, and the supraclavicular foci. This finding, is usually characteristic of subcutaneous emphysema. So, when you feel the crackles under the skin, it's like a bag of rice, right? So that's or maybe gravel. It depends on what you liken it to, but yeah, it's like, it just feels that way. And you could even hear some sounds. So with that in mind, I recognize that there could be further extension. And remember, by the way, that what's making this interesting is that this isn't from the chest. This is the abdomen, right? So it's so far away from the eye. How would we, so without the knowledge of anatomy, like, the way the fascia is distributed and, the continuous nature of the covering of the body, you may not really see the possibility. You may not think of that, at first. How would an abdominal surgery lead to a swelling in the eye? What's the connection? Things like that. So that's why we're discussing this case at this point. She was hemodynamically stable. Her ops were still stable as well. Next slide, please. So because of that, let's just go through the pathophysiology. So usually there's extravasation of CO2 along the fascial planes. what that means basically is, if we're talking about how it progresses, let's say the gas leaked from the abdominal cavity, right? After the insufflation, at a certain level, it's usually during um, uh, uh, the needles are inserted, the air it's insufflated into the peritoneal cavity. It then leaks, it escapes and travels along, like continuous fascial planes. So basically it moves from the peritoneal cavity to the parietal peritoneum, to the transversalis fascia. For those of us that remember our anatomy, the campus, the scarpus fascia, right? And that is continuous with the thoracic, the fascia of the thorax, right? And what we have there is the superficial fascia that overlies the P major, right? Yeah, the P major muscle, all the way to the neck, where you have, the cervical fascial planes. All of that is continuous. So we just need to bear that in mind. But in this case, there might have been, a problem at the trocar site or a diaphragmatic defect. Now, how did we find that out? Like, okay, or rather, during the what's it called, history taking. During history taking, I had asked this lady uh a bit more questions about this because the folder wasn't giving me much. And she actually spoke to me. She said that this had happened to her 10 years ago. So 10 years prior, she had had an endometriosis, surgery for endometriosis. And in that instance, she also had developed the same level of subcutaneous emphysema, which this is a grade 3, by the way. This is a grade 3. Grade 1 is usually confined to the abdomen, right? Grade 2 upwards and so on. Grade 3 gets to the face. So that shows you how extensive this was. And it's also interesting that even with how extensive it was, the level of, affectation, there was no respiratory compromise, which was good. And so she mentioned that, 10 years ago, it actually happened. It was benign, and it took her about 10 days, which is consistent with literature, that it takes about 10 to 14 days to resolve when there are no complications. So yes, risk factors include prolonged surgery, multiple ports, high insufflation pressure. So usually when the surgery takes too long, sometimes, or there's too many ports of entry, we all know that it's quite beneficial when we have, these procedures, the robotic ones, because there's speedy recovery, there's fast, quick discharge times and things like that. But, when we have high insufflation pressure, maybe without the knowledge of this past history, I hadn't seen any place in literature that had pointed to a risk factor of previous history. So now this might actually raise that concern about, okay, if a patient has had this before, it's likely they're going to have it again. So that, surgeons will be more aware of, the likelihood of these kind of complications in patients that have already had it. Yes. So let's move on to the next slide. So just to summarize that section, the pathophysiology, right? It basically moves from the peritoneal cavity, the air, the CO2, through the fascial planes where there are defects, right? All the way to wherever it can, track. It just keeps tracking along those planes and then gets to the subcutaneous tissues of the face. So we've talked about the risk factors. Now for yes. So A to E assessment was conducted. I checked her airway, checked breathing, all of that while I asked those questions. And everything was found to be normal. So I'd also, in line with, the NHS and RC UK, Resuscitation UK guidelines, did all that, escalated to the anesthetist, and he wasn't particularly worried. Like I said, many times this situation resolves on its own, right? It's just the fact that it had happened and can be easily mistaken for other conditions, right? Like edema or something else, or even an anaphylactic reaction, right? Many of us would see that and give wrongly administer clofenamine, right? So, or hydrocort. But in this case, you can see that this was a case of air under the skin. That's all. So this is the importance of this. So the anesthetist then asked me to order a chest X-ray, which is what I did. The chest X-ray actually came back normal. There was no pneumothorax, no pneumomediastinum, but of course, it also on the side confirmed the presence of air, which we could see, as um, along the subcutaneous areas, even down to the chest wall. Okay, next slide, please. So basically for management, like I said, in this case, there was very little that we had to do except observe the patient. So this patient was for conservative management. Usually the alternative would be, oxygen, chest tube drainage, and things like that. You could oxygen therapy, drainage, just basically things like that. And that would be if there was evidence of pneumothorax and things, life-threatening events. So in this case, none of that was the case. So there was no invasive intervention required. The patient was reassured, safety netted with clear instructions. Since she had it before, she was able to calm down, because another thing was the anxiety that came with it. The patient was really worried. But when I made her remember, through history taking about 10 years prior, when she had this surgery to fix her endometriosis, she then realized that, okay, that actually cleared on its own. And that's likely to be the path of the course of action in this case, masterly inactivity, as it were. So yeah, I'll just end with just yeah. So basically, this is what we did: safety netting, patient reassurance. Next slide, please. Yeah. So we talked about how extensive this case was. A grade 3 subcutaneous emphysema, which was interesting for me as an RD to see. The fact that it's important to take detailed pre-op history. This bit of history that she had it before 10 years ago was missed, missed by, the pre-assessment team. And so that's why we had to go through all the other, differentials to get to this. Thankfully, this is easily, diagnosed through physical examination. So just need us to remember that early escalation is always important. In this case, there were no complications, no serious adverse effects following this, and it resolved easily. It resolved, quite straightforwardly. But just for us to remember that we escalate early, we spot these things, we do detailed pre-op history taking and physical examination and all of that. The patient also was reassured because of the history that she gave us. Again, when patients are stable, early escalation imaging is essential. However, there's very little you need to do following that. Next slide, please. Yes. So thank you, everyone. Just for your take home, subcutaneous emphysema, yes, is a recognized complication of laparoscopic and robotic surgery. It occurs due to CO2 tracking right along the fascial planes. The major sign you can see is the crepitus that should prompt immediate consideration of the diagnosis. Another thing you should know is, always perform your A2E assessment, because it really may not be that. It could be an anaphylactic reaction just starting, or angioedema. It could be anything else. So do your A2E assessment. Chest X-ray is essential to exclude life-threatening complications. Most cases are managed conservatively if patient is stable. And finally, please do your pre-op history taking, a detailed history taking where where possible. Thank you, everyone. Thank you. Any questions?
Yeah, thank you, Dr. Okukon. That was incredibly interesting to listen to. I love the mentioning of the rice or the gravel, and very interesting the fascial planes. And one of the comments on the chat was that we were taught during our training in medical school we should never underestimate the importance of good history taking.
Yeah.
So absolutely fantastic. Thank you very much for the presentation. I think if you go to the chat, there is people asking for your name and number. So that says quite a lot after the presentation. I wonder if I can ask you to use the reactions, maybe just to say thank you to Dr. Okokon for the presentation. Now that brings us to a close for today. I'm sorry that we can't answer all your questions that you had for us during the day, but we've tried, because we are recording the session, to stay on time. Now I'm going to ask Erika to add the link for you for your CPD points. This is a link that you need to copy and paste from the chat box, and you can use that link to download your own CPD. But I also would like you to ask you to give us some feedback. So maybe in the chat box, any feedback from today, anything that you would like more of, or maybe less of, that'll be very, very welcome. So maybe if you can spend just a minute to provide that feedback, that'll be absolutely amazing. So just to remind you that we will put the recording on probably next week. I'll need to, this is going to be about three and a half hours of recording. So I will just have to talk to our IT team to see how best we can do that. We've got the WhatsApp number there, and we're just going to give a second or two for the link to come up. So happy to listen to your feedback. If you can put your feedback about today in for us, that'll be absolutely fantastic. Thank you for all the fantastic comments. Very, very much appreciated. We're just going to get that link for you. Right, so just give us a second. Thank you for all the comments, and I'm just going to wait for the comments to slow down a little bit, and then we're going to put the link on for you. Can I also say thank you very, very much to Erika. Erika was behind the scenes to provide us with all the slides going. So I've put the link on there for you. If you want to scroll down to 1233, the link is there for you to get your certificate. I'll do another one just to make sure that you've got it quite a few times there. And we certainly, with all your feedback, I would love every one of you that have attended today. I hope we have at least sparked an interest in doing a case study or something interesting in medicine or an audit to share that with us, or the learning from what you see on your daily practice. So from that side, I'm going to put the link on just one final time for you to have if you want to copy and paste that. I will say thank you very, very much to all our speakers today. It was absolutely amazing listening to you and listening to all the insights. And thank you very, very much for your hard work. I'm going to close the session now. I'm going to keep it open for another 5 minutes until 12:40. And then we will close it down and end the event for the recording. But happy for you to slowly go and enjoy your weekend. And if you're working this weekend, don't work too hard. Cheers. Bye-bye. So you don't have to send the form anywhere. The form will be only for you that you can upload to your appraisal, your CPD form. So keep that form with you, but it'll give you some details on what was happening during the day. So just keep that. It's just for personal use for your appraisal.